All right, so the question revisions. So there are three sections. The first part is multiple choice questions. So, and that's the one we start with. It's saying, in treatment of peptic ulcers, cytoprotection is provided by which of the following drugs? Ranitidine, magnesium trisilicate, omeprazole, misoprostol. When you look at peptic ulcers, you have got an ulcer in the stomach, and what you want to do, or the aim in the treatment, is you want to basically reduce the acid production or to increase the production of agents that protect the wall of the stomach. For example, the mucus and the bicarbonates which neutralize the acid. Ranitidine, this guy is a H2 inhibitor, the histamine receptor inhibitor. And what happens is that if these histamine receptors are stimulated, they'll stimulate the parietal cells to produce acid. Omeprazole is a proton pump inhibitor, and that also prevents the production of acid. Magnesium, on the other hand, is an antacid. It basically tries to neutralize the acid by chemical reaction. Misoprostol is a prostaglandin E1 analog, PGE1 analog. And since it is an analog, what this guy does really, prostaglandins, their role in the stomach is to enhance mucus and bicarbonate secretion. So if this is our stomach and we get to produce a lot of mucus and a lot of bicarbonate, these guys are protecting the walls of the stomach from the acid. That's how they act as protection. So misoprostol, prostaglandin analog or a prostaglandin agonist, is cytoprotective in nature. Number two is saying the following laxatives also has a role in the management of hepatic encephalopathy. Magnesium sulfate, lactulose, bisacodyl, and then docusate sodium. When you look at magnesium sulfate, it has got a lot of uses, of course. One of the biggest uses for magnesium sulfate, we'll discuss it later on when we start talking about the drugs that you use for someone that is pregnant. Okay. Magnesium sulfate is going to be used in pregnancy basically to prevent seizures if someone has got high BPs, a pregnant woman has got high blood pressure. So, in other words, we use it in a condition known as a preeclampsia to prevent preeclampsia from going into eclampsia, which is seizures when a pregnant woman has got high BPs greater than 140 over 110. And then you have got lactulose. Lactulose is a laxative. You know, if we say something is a laxative, it means that it is trying to soften the fecal matter so that you can be able to pass. Because if someone has got constipation, constipation can either be a difficult in passing stool problem, it can be in the GI is not contracting really, or the stool is too hard, so it has to be relaxed or made soft. And lactulose is important in also management of hepatic encephalopathy besides it being used in a constipation. And how does it really do this role? How does it perform that role? So when you give lactulose, it goes in the GI. Let's say this is our large intestine. Lactulose is not going to be absorbed. So it is still in the wall of the intestine, not in the wall, but in the lumen. Okay. And while in the lumen, because in the lumen you have got bacteria here. And bacteria, will start breaking down this lactulose. Okay, so it gets the lactulose and breaks it down into lactic acid and also acetic acid. And what happens is that because you are forming acid, this acid is going to acidify the gut content. Whatever is in the GIT will be acidified. And that will mean because in the GIT you also have ammonia, this ammonia is going to be acidified and you are going to have ammonium. And this ammonium cannot be absorbed. And so what happens is that instead of this ammonia can be absorbed and taken into blood. If it goes into blood, it is going to end up going to the brain, causing encephalopathy, okay, manifesting with signs of problem or irritation to the brain. And really, what happens in hepatic encephalopathy is that the liver is finding a challenge because if you have got too much, look in the breakdown of amino acids, when the amino acids are broken down, you form the urea and you form these other metabolites, you form the ammonium. These things have to be processed to less toxic products. But sometimes the liver can be overwhelmed such that it cannot process all these ammonium, the ureas, and so they end up going to the brain. And that is what results into this hepatic encephalopathy. So because you're converting the ammonia to ammonium, ammonium can't be taken into blood and so it can't go into the brain, and so that's how it's being used in the treatment of hepatic encephalopathy. Someone has got a liver disease in which they cannot process this ammonia that is bad, and so the ammonia now is not going to accumulate in the brain. I hope that makes sense. And then number 3 is saying stimulant purgatives are avoided in constipated pregnant women prior to colonoscopy, prior to colon surgery, prior to radiograph of abdomen. Again, for the treatment of constipation, when you are treating constipation, we have got what we call purgatives and we also have laxatives. And I want you to understand this a bit, okay? Purgatives and laxatives. One of these classes of drugs has got just a mild action, like it's not that tough. The other one is so strong. Laxatives, they basically soften the stool. They loosen the stool and increase bowel movement so that you can pass the stool. But take note, it has got milder action. And then you have got purgatives, also known as cathartics. These are substances that accelerate defecation. They promote rapid evacuation of the intestines, and they are much stronger when it comes to the action. On the classes of the drugs that you use in the treatment of constipation or the laxatives and purgatives, you have got the bulk forming laxatives. These ones will basically get to increase the volume of the stool. And then you have got osmotic laxatives, which basically increase the water content of the stool, hence softening the stool. And then you have got the stimulant or irritant laxatives. And how these guys really work is that they'll act by direct stimulation of the nerve, okay, in the colonic mucosa. You stimulate the nerve so that when they are stimulated, they can cause this pushing of the contents in the GIT. Those are stimulants or irritant laxatives. And then you have got test 2 softeners. We also call them lubricants. These are the ones that to basically make the stool to become soft, and if it is soft, it's going to be easier to pass. So basically that. So when you look at this, stimulant purgatives are going to be avoided in what condition? So you avoid these guys when you are about to do colonic surgery. Remember we said stimulant purgatives basically promote evacuation. They basically promote the removing of the contents in the GIT. And why do you avoid them in colonic surgery? So what happens is that, of course, we have got different examples of these stimulant purgatives. For example, you have got sodium picosulfate. Okay, so what happens is that once you give these, okay, let's talk about the colonic surgery itself. It's just a procedure where you are trying to cut, right? Cut some part of the colon, which is the large intestines, basically. And so the way stimulants purgatives work, example I said, we have got sodium picosulfate, you have got a common drug known as Sena. There is also Besa, cordial. The way these guys work is that they are going to irritate the mucosa of the large intestines, thereby stimulating the mesenteric plexus. And once we stimulate the mesenteric plexus, what is going to happen in that case is that there's going to be bowel contraction. So there is now going to cause the large intestine to contract. It also leads to electrolyte imbalance. When the electrolyte starts going into the GIT, they pull water with them. And it also leads to damage of the mucosa when there is a stimulation. Okay, so in surgery, especially when you are talking about the colon, the bowel must be prepared gently and thoroughly. So you are trying to remove, of course, during uh, colonoscopy. Sorry, not colonoscopy, that is viewing, but during colon surgery, before you can cut the colon, you want to make sure that you evacuate whatsoever is there. But you don't want to use these stimulants because they actually leave some injury also to the colon, and you don't want that. Okay, they cause some inflammation and trauma. So in this case, you want to give other drugs that don't really cause this trauma because you're about to cause more trauma using the surgery. So you can give osmotic purgatives that will basically promote the water to go into the GIT and then evacuation happens. Okay, so that is that. That's that for this one. Please, if you have got a question, feel free to be able to ask. Number four is saying following classes of drugs are used in gastroesophageal reflux disease except serotonin blockers, proton pump inhibitors. Now, gastroesophageal reflux is where you have got your stomach, which I believe you will remember very well from our anatomy, isn't it? You have got there, you have got this part, and then you have got the fundus, the angularis insulae, and then you have got the lesser curvature, greater curvature, which is not important. But take note, you have got a sphincter here, the lower esophageal sphincter. The acid here can go back. So the treatment of gastroesophageal reflux disease is basically the same treatment as the one for peptic ulcers because the same problem is the acid. When you give proton pump inhibitors, they reduce production of acid, histamine blockers, and also prokinetic drugs. Prokinetic drugs, these are drugs that will basically promote GI motility. Okay, like you to promote contents from to, into going downwards, and so the acid will not really have that much effect. But the serotonin blockers, these really don't are not used in the treatment of this condition where I've got a lot of production of acid. Instead, this guy is like for the serotonin 5-HT3 antagonist or 5-HT4 agonist. Those are used in someone that has got nausea or vomiting, so they're antiemetics. Number five is saying suggested features of oral rehydration salts for maximal water absorption in the gut includes osmolarity in the range of 200 to 300 milliosmoles per liter, sodium 20 milliequivalents per liter, potassium about 75 milligrams per liter, glucose sodium ratio 3 to 1. So for ORIs, this is for the treatment of someone that has got diarrhea. People that with diarrhea they lose so much fluid. So I want to give them more fluid back. And they lose more potassium. So as you are giving them whatever fluid you are giving them, should give them also some fluid that has got some good amount of potassium too. Okay. Same, they're also losing sodium, so we want to give them fluid that contains some good amount of sodium. And at the same time, whatever fluid that you are giving them should have the same osmolarity as the osmolarity inside our body. So the osmolarity in our body is between 200 to 300, and normally we get 285 there. But this is the osmolarity that you need. Now sodium, these two values for sodium and potassium have been swapped. So you need about 75 milliequivalents per liter of sodium and then about 20 milliequivalents per liter of potassium. Now the ratio of glucose to sodium should be more like should be in a ratio of 1 to 1. So this is why this is not correct. So the best option there is option A. You'll be expected, of course, to know this, especially when you come to pediatrics next year on the word. A 50-year-old male presents with a striking hypertriglycemia. After about 6 months of drug treatment, his triglycemia and the very low density lipoprotein cholesterol levels dropped dramatically, but his high density lipoprotein levels has doubled. This phenomenon is common seen with when you're using antihyperlipidemic drugs, an antihyperlipidemic drug that really decreases the bad cholesterol and then increases the good cholesterol. The best is niacin, vitamin B3. Okay, it's just that you don't use vitamin B3 for at a dose that you normally use it for food. Should be a dose that is a bit higher than the one for food. That's when it starts acting as an anti-lipidemic drug. It's actually the best. But of course, it's mostly avoided because of flushing, like it dilates the blood vessels and that causes blood to be coming on the skin, you become red. Which two groups of drugs used in the management of hypercholesterolemia are associated with myositis? High levels of cholesterol. So the statins and the fibrates, these guys elevate. Uh, they actually cause myositis, the inflammation, the distraction to muscle. Sometimes you also see when the muscle is broken down and then it is thrown into urine, the urine becomes black, rhabdomyolysis. Okay, so that's what you're going to be able to see. Nicotinic acid, the bad effect that normally is the flashing. Like you start seeing these, someone becomes red, such. Of course, that can be represented by giving aspirin before you can give the 30 minutes before you can give this drug, Nasine. Which of the following medication inhibit cholesterol absorption at a small intestine brush border? Now, for the absorption, ezetimibe will stop absorption. And basically, what happens for ezetimibe is these are the intestines, okay? And remember this condition, you have got hypercholesteremia. You have got high levels of cholesterol in the body. So once you've eaten food that contains a lot of these cholesterol, ezetimibe will stop these gas from being absorbed. So since they are not being absorbed, what will happen is that the body says, okay, we don't have any cholesterol. Let's get the cholesterol that we already have. So they'll get the cholesterol that is already there in the body and start breaking it down, and thereby reducing the stores of cholesterol and lowering the levels. That is how ezetimibe works. Number 9 is saying a 50-year-old male presents with striking hypertriglyceridemia. After about 6 months of drug treatment, is triglyceride and very low density lipoprotein. Okay, this one already answered. It's the same. Which of the following is beneficial in NSAID-induced gastric ulcer? PGF2 alpha agonist, PGD2 agonist, PGE2 agonist, PGE1 agonist. Now the PG2 alpha agonist, this guy normally use it in pregnancy. This guy will cause a relaxation of the uterus. Now for NSAID induced gastric ulcer, you use a PG1 agonist like misoprostol. Misoprostol is going to be given and is a prostaglandin to promote the release of mucus and bicarbonate, and those guys are going to be able to shield the uterus. Hope that makes sense, and that's how it helps. Section B, B1 is saying a 63-year-old lady on ibuprofen daily for a few months for osteoarthritis developed melena. Melena is where you have got dark stool, and the darkness is because of blood. And then endoscopy reveals a duodenal ulcer. Which class of drugs would you recommend as a first line therapy for the patient? Give example of drugs that fall in this category. So for the management of ulcers, the first class of drugs that you want to give are the proton pump inhibitors, PPIs. Examples, we can give omeprazole, lansoprazole, esomeprazole. So those drugs, they are the first line treatment for peptic ulcers. So omeprazole, pantoprazole, esomeprazole. What physiological mechanism are involved in ulcer formation because of chronic use of ibuprofen? Why is it that when you use NSAIDs for long, you develop ulcers? Why? Is there anyone that wants to give it a try? Why do you think so? When you give NSAIDs for long, ibuprofen, you get to develop ulcers. Yes, please. Excellent. Thank you so much. Okay. It is basically the arachidonic acid path. Remember, you first have membrane lipids or the phospholipid. This membrane phospholipid can be converted to arachidonic acid. Arachidonic acid can take two pathways, forming the leukotrienes and also forming the prostaglandins. For those prostaglandins, you have got the prostaglandin G1, you have got the prostaglandin E1, E2, F2 alpha, you have got so all those different types of prostaglandins. And for you to do this process from arachidonic acid to prostaglandins, you have got the COX enzyme here, COX1 and COX2. And then for here again, you have got what we call the LOX enzyme, leukotriene, the one that will be forming the leukotriene. At this point, you also have another enzyme. So stopping the conversion of membrane phospholipid to arachidonic acid, you mostly use corticosteroids at that point. Prednisolone, such examples, dexamethasone, and then here this is where the NSAIDs are working. That's why when you're using NSAIDs, arachidonic acid, this stop has been shut off, so it will take another purpose. It will start going in this direction, forming leukotrienes. Leukotrienes are responsible for bronchoconstrictions, and that will worsen in case someone has got asthma. It will worsen the asthma. That's why NSAIDs are contraindicated, like aspirin is contraindicated in someone that is asthmatic. So when you don't form this prostaglandin, because you are using this COX enzyme, remember prostaglandin E1 causes the formation of what? Okay, It causes the formation of mucus and also bicarbonate, which protect the walls of the duodenum or even the stomach. So if you don't have that mucus and bicarbonate, there is no such protection, and that results into ulcers. What is the name of the syndrome that is characterized by hypersecretion of gastric acid secondary to gastric secreting tumor? Anyone who can help with this one? What's the name of the syndrome? Excellent. Okay. So the Zollinger-Ellison syndrome. So in this condition, remember this is our stomach, and somewhere on the pyloric end here, you are going to have the gastric, the G cells, and somewhere on the body on top, you have got the parietal cells. The G cells have got a tumor that produces a lot of gastrin. Gastrin goes to the parietal cells to stimulate them to secrete acid, and so a lot of acid is produced, and that can result also into this condition. Had the Helicobacter pylori caused the ulcer, what combination of drugs would you recommend to the patient and for how long? So when you're looking at the treatment for H. pylori, you want to use what we call the triple therapy and use it for 14 days. If that fails, you can also go to the quadruple therapy. Actually, the failure of treatment worsens the condition. Okay, that's how the treatment of what we call gases is. Okay, there's nothing called gases, it's actually houses. But if you tell someone it's houses, they will even refuse. No, me, I just have gases, I don't have houses. But it's houses. Okay, there's nothing like gases in medicine. So you use the triple therapy. If the triple therapy fails, you can give them the quadruple therapy. And in the triple therapy, what we do is that we can give them a macrolide, yeah, a macrolide, and then you give them a proton pump inhibitor, and then you give them another antibiotic. A macrolide is an antibiotic, all right? So that is the treatment. Macrolide, another antibiotic, and then a proton pump inhibitor. So what is an example of this macrolide that we'll be able to use in this condition? Anyone? There's just one that we use. Oh, you've not yet done antibiotics. Okay. It's clarithromycin. So you use clarithromycin, a proton pump inhibitor like omeprazole, and then you can get another antibiotic. It can either be tetracycline, or you can actually get metronidazole or amoxicillin. Any one of those three. Amoxicillin, metronidazole, or tetracycline. Why should you not give bismuth subsalicylate in children? So because this guy contains a salicylate like aspirin, you want to avoid also aspirin in children because it also contains the same salicylate, and you want to prevent what we call the rare syndrome. That is the fear about the rare syndrome. It is basically a condition that causes liver failure, acute liver failure, and encephalopathy, especially if a child has got a viral infection. B2 is saying an 86-year-old woman with a history of chronic constipation is treated with good relief for her constipation. However, she complains of painful abdominal cramps and embarrassing flatus and wishes to try another medication. What drug is she likely taking that cause the painful abdominal cramps, embarrassing flatus? Anyone? What do you think? Any thought? So for the treatment of constipation, Lactulose, which is a laxative, is a problem because of this painful abdominal cramps and flatus. What laxative has a similar mechanism of action to the drug in A above but will not cause large electrolyte imbalance, so it doesn't cause flatulence and cramps. So another drug that works as a similar mechanism to lactulose is actually also a laxative. We call it PEG, standing for polyethylene glycol. Polyethylene glycol. Number C is saying what laxative lowers the blood ammonia level in hepatic encephalopathy? Anyone to pick that one up? We answered it on the MCQs. Anyone? Okay. It is still lactulose, the same guy that causes these bad effects. Name the drug or drug class that enhances release of calcitonin gene-related peptide, enhancing the release of acetylcholine, thereby being used to treat irritable bowel syndrome. So here we have got one drug that is going to be used for this. We have tegaserod. That's the name of the drug. The drug class, it is a serotonin agonist. Specifically, it is 5-HT4 agonist. Okay. And how this guy really works is that it is going to stimulate the enteric neurons, the neurons in the GIT. Once it stimulates them, there's going to be an increase in what we call calcitonin gene-related peptide. And once this CGRP increases, it also increases acetylcholine. And once acetylcholine is high, remember acetylcholine will cause what? Contraction. So that promotes motility and secretion in people that have got constipation and irritable bowel syndrome. IBS, irritable bowel syndrome, is just a condition where there is different mechanisms, of course. But one of them is that the body's immune system starts to attack its own self, like it starts to attack this GIT. So I've got and that results in inflammation. You have got two diseases that fall under irritable bowel syndrome. You have got ulcerative colitis and the Crohn's disease. Crohn's disease. E is saying what laxative does not soften feces already present in colon or rectum but prevents constipation and it does not treat it. So there is one laxative that does not treat, okay, but it will be able to prevent. And we call them the bulk forming agents. Bulk forming agents. They just increase the mass of the stool. So specifically, we can give an example what is known as bran. Okay. What this one does is that it is just going to absorb water and then increasing the stool mass. So it's a bulk forming agent. The patient above develops diarrhea and you want to treat it. So what happens that when you're trying to treat constipation, you can cause diarrhea. And when you're trying to treat diarrhea, you can end up causing constipation. Okay. So the patient now develops diarrhea. Give two drug classes you would give her. So for the drug classes of diarrhea, you can give what we call anti-motility agents. Remember, in the treatment of constipation, we are giving drugs that promotes contraction, or drugs that are motility in nature. They cause contraction. So the anti-motility agents you can give, for example, loperamide. And then you can also give what we call adsorbents, like that, adsorbents. And what these drugs really do is that they are going to bind toxins, fluids, and bacteria, and so reduce the stool volume. If there's a reduction in stool volume, that can as well help in the constipation. An example is activated charcoal. It is an adsorbent, all right? And then you can also give anti-secretory agents. And these ones, basically, the way they work is that they will reduce CMP. If CMP is low, that will mean that chloride ions will not go into the GIT, into the lumen. If there is no chloride, because where chloride goes, that's where water goes. So it means that water will not go there. So you are promoting the retention of water, and that causes also the diarrhea to cease. You can also give anticholinergics. Remember, the parasympathetic nervous system causes you to go to the toilet because when you're resting, you can go and waste. Okay, but anticholinergics work like the sympathetic. Sympathetic, when you see a lion, you don't have energy to go to the toilet. You actually don't even want. So that's how anticholinergics work, like hyoscine, atropine. So these will be able to cause a smooth muscle tone reduction. When you reduce the tone of the smooth muscles, that results in contraction. Okay, if there's contraction, you really not cause. It's like you're preventing movement because what will stimulate defecation is because the smooth muscles have relaxed. But if you contract them, think of you've contracted a sphincter, it's present in the smooth muscles, you can't defecate. Another class is what we call probiotics. Now, these probiotics, these ones basically they just reduce the gut flora. You know, in the gut you have got normal flora. Okay, bio means life. So these guys will break down these gut flora and thereby reducing inflammation because this flora that will cause inflammation and that is going to enhance the mucosal barrier. Okay, because if there is inflammation, that can result in diarrhea. And then you also have antibiotics because there are some forms of diarrhea. In microbiology, we are going to discuss types of diarrhea. In pathology, we'll discuss, of course, diarrhea also. Pharmacology, we've discussed already. But in microbiology, we discover that we have got specific organisms that cause bloody diarrhea and specific organisms that cause water diarrhea. For example, I've got Salmonella, Shigella. These guys will cause diarrhea. So if you want to treat diarrhea caused by these guys, you want to treat them by giving antibiotics. For example, metronidazole. Okay. Do you know the common name of metronidazole that is given, like that we use on the streets? If they ask you to go and buy a drug, because I don't say metronidazole. Anyone who knows the common name? Anyone? Okay. So name one side effect of selected antidiarrheal drug. So one side effects that you can think of an antidiarrheal drug. Of course, there are a lot, but just mentioning one, most of the drugs you say nausea and vomiting as a side effect. But for this one, I don't think that would be too necessary. But a common one you can give, as I said earlier, is antidiarrheal drugs cause constipation, and then the laxatives cause diarrhea. Okay, for example, loperamide, which is an antidiarrheal, it will cause constipation. Okay, and then there's even this one: give two contents of the oral rehydration solution. Now we had already mentioned this earlier. So in the ORS used to treat diarrhea, I've got sodium chloride, potassium chloride, you have got glucose, you have got water. So those are the components: sodium ions, potassium chloride, citrate, glucose. They are of course having also specific concentrations. A 42-year-old man was started with an antihyperlipidemic drug 2 weeks ago for elevated triglyceride and low high density levels. He is complaining of an uncomfortable flashing and itchy feeling that he thinks is related to the drug. What drug is most likely to have been taken? What do you think? Someone comes with flashing, itching. What anti-epidemic drug have they likely taken? Anyone? So more likely, this person has taken niacin or vitamin B3 or nicotinic acid. That's the one that causes this flashing. What would you do to help you manage these adverse effects prior to therapy? So 30 minutes before, you are going to give him aspirin. And how does really aspirin get to help in this condition? So what aspirin does is that it suppresses prostaglandin release. These are prostaglandins that will be able to cause these blood vessels to be able to relax. Okay, they remember the this misoprostol that we are talking about. Besides it being used here, earlier on, misoprostol is a PGE1 analog. We say that it's used to treat ulcers. But in pregnancy, it is also used specifically for abortion. Because what this guy does is that it will promote relaxation of smooth muscles. If the smooth muscles relax, you are going to abort the child. Okay. Now, specifically for abortion, we use what we call misoprostone. Misoprostone. But take note, this guy causes relaxation of the smooth muscle. Same with blood vessels. If they've relaxed, what that is going to do is what really relaxation does. Okay, it depends also with the blood vessel that you're talking about. If you relax the blood vessel, it means that it has now become big, isn't it? Blood can flow all the more. But in this case, what we are saying is that aspirin prevents this, comes and stops the production of these prostaglandins. So there's no relaxation, and so there will be no flashing because there's no much blood that is going to the area. Give two other. Okay. C. What class of drug is the initial choice for the treatment of hypercholesterolemia and has a modest increase in high density lipoprotein cholesterol? So the one, it is the initial choice of treatment for cholesterol, high levels of cholesterol. Remember, high levels of triglyceride, the initial treatment are the statins. That's a recommended initial treatment for high levels of triglyceride. But high levels of cholesterol, the initial drug that you want to give in this case, is it the question? So what class of drug is the initial choice for the treatment of hypercholesterolemia and there's a modest increase in high density? Okay. Yeah, so here also is going to be the statins, the H actually the in the initial treatment, not of the one I mentioned, the triglyceride, but statins are going to be used for cholesterol. Because what the statins do is that in the pathway for the synthesis of cholesterol, you have got the rate limiting enzyme, which we call HMG-CoA reductase. That's the enzyme that is going to be inhibited by these statins. So statins are basically for high levels of cholesterol. Give two other independent effects of this drug in C. So we've said in C it's statins. So statins have got other benefits, like they have got anti-inflammatory effects. They also reduce the rate of bone resorption and that lessens osteoporosis, and then they decrease the risk of stroke, especially in the elderly. Give two major side effects of the drug in C. So what are the major side effects of statins? Number one, it can result in two, myopathy or myositis. So you'll be able to see muscles being broken down. You can even see dark urine abdominosis. myolysis, and then another side effect is hepatotoxicity. So these are the major two side effects: hepatotoxicity and myopathy or myositis. What class of antihyperlipidemic drugs reduce plasma cholesterol but no effect on triglycerides? Yes, now. So this one which reduces cholesterol, remember statins reduce, uh, yeah, the statins reduce cholesterol, but now this one we want what reduces also cholesterol but has no effect on triglyceride, because the statins also have got an effect there. So this one, it is the what we call the bioacid binding resins. So these guys are involved in basically interrupting what we call the enterohepatic circulation of cholesterol, because normally when you have got this uh, bile that is released by the liver, it is the one that breaks down cholesterol. So if you have got a bile acid binding resins, what these guys do is that they are going to be able to bind bile acids, and so it is disturbed from going back to the liver in the enterohepatic circulation, thereby causing it to reduce in the body. Because one, if you've not taken it back into enterohepatic circulation, it means that you are going to use other forms to try to make the more bio, not the one that is in the jet, because that will be removed. And as you are trying to make the new one, you are reducing what is already there, the cholesterol that is already in the body, but it has no effect on triglyceride. Please take note of that. Example of these bio binding resins includes cholestyramine, cholestyramine, see it like that, cholestyramine, and the cholestipo. Number G is saying name the drug that acts within the intestines to reduce cholesterol absorptions and shows complementary action when combined with statins. So this is ezetimibe. It's the one. It's a very good drug, especially when you combine it with the statins. Then we have got these matching questions. So match what is in A with B. So A is showing the side effects, B is showing the drug. Myopathy and hepatotoxicity. Which drug is going to be paired with myopathy and the hepatotoxicity? Okay, the statins. Thank you. And then cutaneous rash and itching. Okay, rash, the itching, vitamin B3, isn't it? Niacin. The itching and the rash. And then bloating and impaired absorption of lipid soluble vitamins. Bloating, which one is that? Which one do you think? Okay. What have you said again? Okay. Yes. Because these bile acid sequestrants, they will simply cause the release of the. Remember, what they are doing is that they are preventing a enterohepatic circulation. So the bile is still in the GIT, and that can lead to the attraction of water that causes bloating. Cutaneous flushing and the insulin resistance. Okay, so for this one, I think I didn't see that clearly. The flushing is the one for vitamin B3, isn't it? And then, so option 2 was saying cutaneous rash and itching. Actually, even itching itself can be caused by the niacin, vitamin B3. But specifically, cutaneous rash and itching, I shouldn't have matched this one really with this one, because I read it too quick. The flushing is because of the dilatation of the blood vessels on the skin, and that makes you to become red. That's because of vitamin B3. But cutaneous rash, that one is going to be paired with. Mhm. Any thought on that one? What can you pair up with? Okay, the fibrates. And then number five, diarrhea and arthralgia. So this guy causes diarrhea, ezetimibe, and the reason as to why it even does that, like the causing of the diarrhea, is because of the. Remember, this guy ezetimibe basically prevents the absorption of your lipids, so they are still in the GIT. The water can actually end up going there causing the diarrhea. So that is what happens. So we had initially said the statins result in myopathy and also they are hepatotoxic. I hope that is okay. Is there any question here before we proceed? We have got one more question to be done. All right. Match the following drugs used to manage POD or GERD. So that was supposed to be GERD, gastroesophageal reflux disease, with a mechanism of action. So neutralizes the acid in the stomach. So which one among us is an antacid? Oh, I've even mentioned already. I didn't know that they gave that one. So antacids neutralize. And then to inhibit gastric acid secretion through irreversible binding and inactivates parietal cells, the proton hydrogen potassium ATPase. So which drugs work on the hydrogen potassium ATPase? Anyone? It's a proton pump inhibitors, isn't it? The physical barrier protects the luminal surface and also from gastric acid and pepsin. So the physical barrier. Okay. Sucro, sucra, sucralfate protects the luminal surface and also from gastric acid and pepsin. I'm going to come back to it. There's something I want to show you for this. Protects against NSAID-induced ulcer by inhibiting secretagogue-induced acid secretion. How about this one? Okay, so this one is misoprostol. Yes. Remember, it will basically cause the acid to be produced, specifically to eradicate H. pylori. Okay, so this one is what remains, isn't it? H. pylori is a bacteria that has to be dealt with using antibiotics. Tinidazole, clarithromycin, which is a macrolide. The physical barrier protects luminal surface. So yeah, this guy will basically get the GIT and you are trying just to coat it so that the acid doesn't get to harm the GIT. So basically that is it for this one.